All right, welcome back for Lab 5. So hopefully you've got the lab sheet in front of you. So remember, you can access that in Canvas. Just scroll down until you see the hip module, and you should be able to print that lab sheet off. All right, so for Lab 5, we're going to cover, so obviously it's an osteology lab, we're going to cover the pelvis, so each side of the pelvis, and then the femur and the patella. The patella, the more common name for that is your kneecap. So what you're looking at here is the skeleton from the right side. I've taken off his right arm. You can see his left arm still on there, but you're looking at him from, it's a lateral view from the right. And if I click ahead one slide, then you can see that we've removed the femur, and so now all you're looking at is the innominate bone. So in terms of what the innominate bone is, if we consider the pelvis as a whole, it has a bone on the right, a bone on the left. Those two meet in the middle, an area called the pubic symphysis, and then on the posterior aspect between the two innominate bones, then you have the sacrum. So each side of the pelvis then, the right side and the left side, is formed from what's called an innominate bone. And each innominate bone has three parts to it. So there is the ilium, which is the upper portion of it, so all up in here, basically kind of through this top third of the acetabulum, which is the socket. All of this up here is the ilium, and then that infero-posterior aspect, or posterior-inferior aspect back here, where I'm mousing over, that is the ischium, and then this anterior aspect right here is the pubis. And if you look at the anatomy drawings that are posted in Canvas, you'll see that it's kind of color-coded. So the ilium is sort of a tannish yellow color, the ischium is blue, and then the pubis is red. So in an infant, those three are not yet fused, and they come together to form one bone, which is the innominate bone. So what you're looking at here is the right side of the pelvis, but effectively then you're looking at the right innominate bone. So we're going to start on the superior aspect. We're going to start on the ilium, and we're going to start on the anterior portion of the bone. So you can see my mouse has popped back up. And so our first landmark is the anterior superior iliac spine, or ASIS. And so that is this really obvious projection right there that I'm mousing over. So the ASIS is a pretty important landmark. It's pretty easy to find. For most people, it's right about belt level. It's a flat spot on either side, right about belt level. And so where the name comes from, obviously, is the location. So it's anterior, it's in the front. It's superior, so it's on top. And then it's an iliac spine, so it's a projection off of the ilium. Because below that, we have our anterior inferior iliac spine down here. So you've got two spines. There's an anterior superior one and an anterior inferior one down here. Returning to the anterior superior iliac spine, important parts about it, or important things to know about it. One is it's the site of origin for the sartorius muscle. So it originates there. And then two is that it's an important landmark if we ever need to look at alignment. So if we need to look at, maybe you've heard you have a tilted or rotated pelvis or something to that effect. One of the ways that we measure that, or one of the ways that we evaluate that, involves looking at the anterior superior iliac spine, and we can compare side to side to see if you've got a lateral tilt, so maybe your right leg is longer than your left or something like that. And then we'll compare it to one of the landmarks on the back to look at whether your pelvis is tilted forward or backward, any of that kind of stuff. So the anterior superior iliac spine then, again, is right here. And so then the next landmark is just below that. So that's our anterior inferior iliac spine, or AIIS. Again, it's on the front, but it is below the other one, so that makes it inferior, but it's also an iliac spine. So the AIIS is right here. An important thing to know about it is that's the origin of the rectus femoris muscle. So rectus femoris is one of the four quad muscles, the quad being the group of muscles on the front of your thigh that extend your knee. Rectus femoris is the only one of the four that crosses the hip joint. So at the hip, and the name for that is the acetabulofemoral joint. So at the hip, rectus femoris is a flexor. The rest of the quad group, so vastus medialis, vastus lateralis, vastus intermedius, none of those three cross the hip, so all of those three are only knee extensors. Rectus femoris that originates there at the AIIS is the only one of the four that has any effect on the hip. Then if we move up top, So the iliac crest, so if you think of the crest of a wave as being the top of it, the iliac crest is up here. So all of this is the iliac crest, and that's pretty easy to find in us. If you kind of go into your abdomen and then squeeze in and push down, you should be able to find your own iliac crest. So it's a pretty obvious bony ridge there, basically kind of near the midpoint in terms of superior, inferior, kind of near the midpoint of your abdomen. So then we got to switch views to look at the iliac fossa. So now you're looking at the right innominate bone from the medial aspect. And so on the medial aspect of that bone is our iliac fossa. So all of this area in here is our iliac fossa. And that's an important landmark because the iliacus muscle originates there. So obviously iliacus, iliac fossa, those two go together. But iliacus runs together with another muscle called psoas to form one muscle called iliopsoas. And psoas actually originates up here in the low back, so it originates from these transverse processes of L1 through L5. So psoas originates up here, comes together with iliacus, which originates down here. Both of those two go in front of the pubis and actually insert down here on this landmark that you can see, which is the lesser trochanter. So those muscles collectively, iliopsoas, are a really important hip flexor, and that's one of the muscles that tends to cause problems if it gets stiff or short. It can cause low back pain, can cause clicking in the pelvis, all kinds of different stuff. So at any rate, why it matters for now is here in the iliac fossa is the origin of the iliacus muscle, so essentially half of the iliopsoas muscle. Then, if we go back to our other view, so now you're back to the lateral view of the right innominate bone. So now we're going to go to the posterior superior iliac spine, so that's back here. So if the anterior superior one is right there, then the posterior one just moves straight backwards. So the posterior superior iliac spine is there. So the PSIS is important really for helping us identify alignment. So I mentioned that one of the things that you could look at is an anterior or a posterior tilt. So in the case of the pelvis, if you've got an anterior tilt, what ends up happening is that the ASIS is rotated down, and then the PSIS is rotated up. So when that happens, it hyperextends the low back. And so that's the kind of posture that we would associate with somebody having, let's say, a beer belly, or in a pregnant woman as well. You're going to get that anterior tilt of the pelvis. So to evaluate if somebody has that, and the reason you would do that is to evaluate whether or not their hip flexors, specifically iliopsoas, is too tight or are too tight. You would evaluate the relationship between the PSIS here and the ASIS. If the PSIS is much higher than the ASIS, that's an anterior tilt. Conversely, if we go the other way, the ASIS is, if that's way higher than the PSIS, then that is a posterior tilt. That could indicate either overdeveloped hamstrings, maybe overdeveloped rectus abdominis, so your abs and oblique muscles. That may play a role then in producing that posterior tilt. Between the two, though, posterior tilt's not very common. It's mostly an anterior tilt that you're going to see. So the PSIS is an important landmark for that. That's also the one that produces butt dimples. So if you've looked at somebody from the back side, near the top of their pelvis, you may see a little indentation, one on the right and one on the left. That is their PSIS that you can see. Obviously, you can't see it in everybody, but in some people it becomes really obvious if they're wearing really low pants or something like that. You can see their little indentations there where the PSIS is. The other one, just below that, is the PIIS, so the posterior inferior iliac spine. So that forms an important projection that interacts with the sacrum to form the sacroiliac or SI joint. But other than that, the PIIS, we don't really use it very much. It's not very involved clinically, so we don't talk about it a whole lot. But the PIIS is right there. Now the next three are gluteal lines, and they are not super obvious on this thing, on this skeleton here, nor are they super obvious on the plastic bones in class, but they're fairly obvious on the anatomy drawings that are up under the Netter PDF. So at any rate, there's three gluteal lines. There's a posterior gluteal line, an anterior, and an inferior. And so the way those work, there we go, got my mouse back. So the posterior gluteal line is kind of in through here. So that's the one that you can see, and that's the most obvious one on most innominate bones. So the reason the posterior gluteal line matters is that you've got three gluteal muscles. So you've got gluteus maximus, which is your big superficial butt muscle, and then you've got gluteus medius, which is kind of in through here, and then you've got gluteus minimus, which is down here. So gluteus maximus, again, big superficial butt muscle. It's a really important hip stabilizer, so it's a hip extensor, but also an AB and AD ductor, depending on which portion of the muscle you're talking about. And then glute medius, which would be kind of in through here, that's a muscle that is an important AB ductor and internal rotator at the acetabulo-femoral joint. And then glute minimus is the same thing as glute medius, so important AB ductor and internal rotator at that joint. So where that all ties into the gluteal lines is that with our posterior gluteal line back here, glute max originates posterior to the posterior gluteal line, so kind of in this area that I'm mousing over. And then gluteus medius originates between the posterior and anterior gluteal line, so kind of in through here. So this general area would be where we've got the origin of gluteus medius. And then between the anterior and inferior gluteal lines, which again would be kind of down in this area, so the muscle's origin is sort of in this region, that's where you've got gluteus medius. So gluteus maximus originates posterior to the posterior gluteal line, gluteus medius is between the posterior and anterior, and then gluteus minimus is between the anterior and inferior gluteal lines. So that's why each of those matters. And then going back to the posterior aspect, we've got our greater sciatic notch here. So it's a pretty obvious landmark, this big. It's sort of a candy cane shape on the innominate bones that we'll handle in class. But all of this is the greater sciatic notch. Your sciatic nerve comes out through here, which innervates the posterior aspect of your thigh. Then we've got the ischial spine, which is this thing. So you've got ligaments that run from the ischial spine over to the sacrum and over to the ilium up here near the PSIS, and so that's the significance of the ischial spine, is it serves as a site of ligament attachment. Then just below that is the lesser sciatic notch. It's not super obvious from this view, but it's pretty obvious on most of the innominate bones in class. If you find the little ridge here that comprises the ischial spine, just below that you'll find an indentation, and that's your lesser sciatic notch. Then we've got our ischial tuberosity. So all of this down here, so on the inferior and posterior aspect, now we're on to the ischium. And actually, technically we were when we were back here on this spine. So the dividing line between the ilium and the ischium is somewhere approximately here. So above the ischial spine, kind of in this region. So again, now we're on to the ischium. So then here is the ischial tuberosity. All through here, it's a pretty rough looking area, and if we click to a posterior view you can see it a little bit better there. So that rough area right there is the ischial tuberosity. That's an important landmark for a couple of reasons. One is that sometimes it's referred to, like in a yoga class, as being your sits bone. So when you sit with your hips in flexion, then you're actually, what transfers your weight from your trunk to your chair is the ischial tuberosity. So it's what you actually sit on when you're seated. The other thing about it that's important for us in this class is that the ischial tuberosity is the site of origin of all three hamstring muscles. So you got three hamstrings, semimembranosus, semitendinosus, and biceps femoris, and all three of them originate there at the ischial tuberosity. So sometimes when somebody pulls a hamstring, they grab the posterior aspect of their upper thigh, and what they're doing then is they're grabbing near the origin of those muscles there at the ischial tuberosity. So that's the important part about that landmark. And then the next thing is the ramus of the ischium, which gets a little tricky to find. It's easier to find on the key bone in class, or also on the drawings in the Netter drawings where you've got it color-coded. But if we move anteriorly from the ischial tuberosity, so we start coming this way, this then is the ramus of the ischium. And the reason it gets a little tricky is that divides right here, give or take, and so then we get the inferior ramus of the pubis, and those two run together, and so that's why it gets a little tricky. So basically just this posterior part of this bony ring then is the ramus of the ischium. So kind of all of this area that I'm mousing over is the ramus of the ischium. Then the hole here is the obturator foramen. So remember that a foramen is a hole, and so the obturator foramen is this fairly large hole in the pelvis. Now obviously in all of us, there's not a giant hole in your pelvis. That's covered up by a layer of connective tissue, so a membrane effectively, that serves as a site of muscle origin for two muscles. One's called obturator internus, the other one's called obturator externus, and both of those two are external or lateral rotators of the hip. So they're effectively part of the rotator cuff of the hip. They're going to originate there. So again, you don't have a big hole. There's a membrane there in two of your hip rotators. One of them rotates on the exterior aspect, and one on the internal aspect of that membrane. So that's your obturator foramen, the big hole. And then we're going to go back to the ramus down here. And so again, as we move anteriorly, now we're on to the pubis. So we're on a different part of the innominate bone. And again, on the Netter drawing, this is red. So this is your inferior pubic ramus down here. An important part about it, it's a site of origin of most of the adductor muscles. So adduction is bringing your knees together. So your adductor muscles are more commonly known as your groin muscles, and so most of them, like gracilis, adductor longus, adductor magnus, originate somewhere there along the inferior pubic ramus. So that's the significance of it. And then the pubic tubercle is this little, there's a little bump on either side, you can kind of see it. So that's the pubic tubercle, so a little bump right there. The significance there, so you have a ligament called the inguinal ligament that runs from the ASIS down there to the pubic tubercle, and that helps line off the abdominal cavity from the leg, and so that ligament inserts there. Then, moving on to page 2, so then we got the superior pubic ramus. So the superior pubic ramus, we'll go back to that previous view that I was using. That'll work. All right, so the superior pubic ramus then, so again, we're back to that right view, or view of the right innominate bone. So all this up here is the superior pubic ramus. So you've got another adductor up there. So you've got pectineus, which is that adductor. And then depending upon which textbook you look at, sometimes they'll say that the origin of adductor brevis is up there as well. So important site of muscle origin up there with those two muscles, so two hip flexors and adductors originate there as well. And then the last thing is the acetabulum. So the acetabulum is the socket. So it's kind of like the glenoid cavity or glenoid fossa that we talked about with the shoulder, just a little different name. So the acetabulum there is the socket into which the head of the femur fits. All right, so how to do right and left in the innominate bones. It gets a little bit tricky because obviously both of them have points. So determining which side's the front, which side's the back can sometimes be a little bit problematic. One of the things I would say is if you look at the medial aspect of the bone over here, so if we took off the sacrum, this most posterior aspect back here by the PSIS and PIIS is going to be a really rough area to allow for maximal bony overlap between the sacrum and the ilium. So what I would do if I were you is to find the acetabulum, so find the socket, make that face laterally, and then find that rough area, which is on the posterior aspect. So orient the rough area, you know that's the PSIS and PIIS, rotate that posteriorly, and then have the acetabulum face laterally, and then you'll know that you have a right or a left when it aligns like that. So that's the innominate bone. So then moving on to the femur, skipping ahead a little bit, here we go. So there's your hip joint, which again is the acetabulofemoral joint. So now let's look at the femur in close-up. See if I can get a closer view. Oop, there we go. All right, there's my close-up of the femur. All right, so you're looking at the right femur from the anterior aspect. As you probably guessed, up here at the top on the most superior aspect, this is the head. So again, you can see it's covered in that hyaline cartilage, that nice smooth articular cartilage that'll interact with the acetabulum. The other thing, before I get too far ahead, that you might have noticed in the acetabulum, this little ring here So that is called the lunate cartilage. And it's a really thick ring of fibrocartilage that lines the inside of your hip and helps with shock absorption. So you obviously have got a lot of forces as you land and run and jump and all those sort of things passing through the acetabulo-femoral joint or the hip joint. And so we've got this big ring of cartilage, again, the lunate cartilage, that helps absorb that shock. So there's your femoral head right there. And then the next thing on there is the fovea, which is, so now you're looking at the medial view of the right femur. This little indentation in the head of the femur is the fovea. So in all of us, we have an artery that runs from the acetabulum into the head of the femur that gives the femur its blood supply, at least part of it, or part of the femoral head gets its blood supply from there. And then there's a ligament that surrounds that. So where that becomes problematic is if somebody were to dislocate their hip. What ends up happening, back up a little bit. So if you dislocate your hip, the femur actually goes behind the acetabulum, so it's usually a posterior dislocation. And when that happens, then you tear that artery, and so the femoral head loses its blood supply, or at least part of its blood supply. Most of the rest of it actually comes in through an artery into the neck, which is called the circumflex artery, kind of in through here. But at the very least, you've lost part of the blood supply to the head of the femur, and so when that happens, when any tissue loses its blood supply, that tissue dies. And so in the case of the femur, if this underlying osseous tissue dies, then it'll collapse in on itself whenever you're weight bearing again. So if we take that person and then we reduce their hip dislocation and then have them stand, one of the negative outcomes of that hip dislocation can be that you get a flattening out of the femoral head. And so as you can imagine, that's problematic in that it's tough to walk if your femoral head isn't fully rounded. And so you get, obviously you accelerate the degeneration of the joint. And it becomes really painful and uncomfortable to walk. And so oftentimes those people will need a hip replacement. So you see that in some high-level athletes sometimes, where if they've dislocated the hip, they may need a hip replacement fairly young. And again, it's because of that cutting off of the blood supply to the femoral head. So anyway, that's the head and the fovea. And then, as you would have guessed, so this is the neck. So the neck is just below the head. So that's it through there. Then we have our greater trochanter. So the greater trochanter is all of this on this lateral aspect, and I'll switch to a lateral view. So all of this then is the greater trochanter. The significance of the greater trochanter, it's actually a lot like the greater tubercle in the humerus. So remember, in the case of the humerus, 3 of the 4 rotator cuff muscles inserted into the greater tubercle. Very similar idea in the hip, except now it's the greater trochanter. And your external rotators, also known as the deep 6, and we'll talk about their specific names next time, but those muscles insert there into the greater trochanter. So that's the importance there. The external rotators of the hip insert into it. Then we've got our lesser trochanter, which is easier to see on this posterior view. So if the greater trochanter is this big one right here, the lesser trochanter is this little one right here. The importance of the lesser trochanter is that's the site of insertion of iliopsoas, again, that primary hip flexor muscle that I talked about earlier. So iliopsoas inserts there into the lesser trochanter, and then between the two is our intertrochanteric crest. So when we get to lab, you'll see there's a pretty obvious bony ridge right there that I'm mousing over. So intertrochanteric obviously means between the trochanters. And so it's a crest, it's a ridge. So the intertrochanteric crest is this really obvious ridge right there. Then the next thing we've got is the linea aspera, which means rough line. So the linea aspera is this rough line along the midline of the posterior aspect of the femur. So all of this that I'm mousing up and down on is the linea aspera. So the linea aspera is going to be important because our adductor muscles, so again our groin muscles, insert along there, but also several of your quad muscles originate along there. So there's a lot going on along the linea aspera. If you look at the Netter slide that has all the origins and insertions, if you look at that posterior aspect, there's a lot of thin little blue lines right there along the linea aspera, and you can see how many things insert along there. Again, primarily it's the adductor muscles. Then we've got our popliteal surface, which is this flat area down here at the distal aspect of the linea aspera. So the popliteal surface, again, is a little flat area right here. Then we've got our adductor tubercle, The adductor tubercle is on the medial aspect because, again, your adductor muscles are your groin muscles. So it's this little bump right here. And the significance of that, I'll switch to medial view and see if we can see it a little bit better. Not really. It's kind of in here. But the significance of that is one of the adductor muscles, the largest of them, adductor magnus. And again, magnus means the great one. So adductor magnus inserts there. It also inserts along the linea aspera as well. So it's a big muscle, big insertion, but one of its points of insertion is into that adductor tubercle. Then we have the epicondyles and the condyles. So on the femur, I'll actually switch to an inferior view here. It's probably the easiest way to find it. All right, no go on the inferior view, that's okay. So what you'll see here, so again, we're looking at the right femur from the front. So you can see this hyaline cartilage down here. So those are the two condyles. The medial condyle, obviously, is the one that's on the same side as the femoral head. So your medial condyle is down here. The lateral condyle is over here. The thing to know about the condyles is those are the parts of the femur that actually sit on top of the tibia, which is your shin bone, whenever you're standing. So the medial condyle is a little bit larger than the lateral condyle, so that can help you with medial lateral, although the much easier method is just to look at the head. The head's on the medial aspect. But again, the condyles, the importance of them, so they're covered in hyaline cartilage and they sit directly atop the tibia whenever you are standing. And then the epicondyles, those are just above the condyles. So where that hyaline cartilage ends, in all of us, there's actually a pretty obvious ridge, and I can show you how to find it if you're interested. It's not that hard. But where that ridge is located, that's the end of the condyle. And then everything out here, where the hyaline cartilage ends, all of this then is the epicondyle. So the epicondyles are above the condyles. So your medial epicondyle is here. Your lateral epicondyle is over here. And then we've got the intercondylar fossa or intercondylar notch. So that's on the posterior aspect back here. There we go. So that's, again, intercondylar between the condyles, so that indentation is right there. So in terms of right and left in the femur, I think that's one of the easier ones. So with right and left in the femur, the way that I would do it is pretty similar to what I would do with the humerus. So find the head. Obviously, that needs to face medially because that needs to interact with the acetabulum, which is the socket. So the head needs to face medially. And then find the linea aspera, right? So you got a really obvious rough line on the posterior aspect or the back of the bone. So if you orient it to where the femoral head faces medially and then the linea aspera is located posteriorly, then you'll know whether you have a right or a left. Which then leaves us with the patella, again, your kneecap. So again, I try to change the views on you in terms of right and left. So you're looking at the right patella from the anterior aspect, and again, that is your right kneecap. So things to notice about it, in terms of the landmarks, so it's a little bit confusing in terms of the terminology because the base is actually up here. So the base is more proximal. Normally we would assume that the base is on the bottom, so you would think it would be more distal, but it's not. The base of the patella is actually the rounded top part. Then the apex, so if you're thinking about something like a pyramid, the apex is the point, so typically that's on the top. But in the case of the patella, it is not. So the apex of the patella is this point down here. It is actually inferior or distal. So this is the bottom down here at where the apex is. The base, again, is on top. So in anatomical terminology, the base is proximal and the apex is distal. And then if we look at the posterior aspect, so this is the more medial aspect. Now on the left side of the screen, still your right patella. This is the more lateral aspect on the right side of the screen. So the way to determine left and right in the patella is actually one of the easiest bones that we'll do this semester. Because there's a little bit of a height difference between the two, there's a little bit steeper angulation on the lateral aspect of the bone. And so what you do to find right and left in the patella is you take the apex, which again is the little point down here, take the apex, point it away from you, and then set the patella down on the table. It'll lean either left or right. whichever way it leans is the side on which it belongs. So if you place your patella with the posterior aspect with that articular surface facing down, so articular surface down on the table, apex facing away from you, if that patella leans right, it is a right patella. If it leans left, it's a left patella. So that one's pretty straightforward. Then only a couple things left. So we've got our joints. We're going to cover 2, and then we'll actually talk about the ligaments of those joints in class. So we'll skip over that for this portion of the lecture. So the first joint is the acetabulo-femoral joint. So now you're at the top of page 3. That's the anatomical name for your hip. So that's the acetabulo-femoral joint there. So in terms of actions, it's the same basic setup as we see in the glenohumeral joint, aka the shoulder. So you've got acetabulo-femoral flexion, which is just bringing your leg straight forward at the hip. So it looks just like glenohumeral flexion. Then you've got acetabulo-femoral extension, which is going straight back. So again, same look, same appearance as we get in the glenohumeral joint. So bringing your arm straight back is glenohumeral extension. Bringing your leg straight back is acetabulo-femoral extension. So we see extension whenever you push off. So every time you take a step or if you jump or any of those kinds of things, that is acetabulo-femoral or hip extension. Then we have abduction, which is taking your leg away from the midline. So if you bring your knees apart, that is hip or acetabulo-femoral abduction. If you bring your knees together, that is acetabulo-femoral or hip adduction. So bringing the knees together is adduction, because again, you're adding it back to the midline of the body. If you bring your legs apart, like you do when you're skating and things like that, then that is hip abduction. And then hip internal rotation, or acetabulo-femoral internal rotation, is to take the front of the femur, rotate it toward the midline. So again, looks very similar to what we did in class with the glenohumeral joint. And then acetabulo-femoral external rotation, take the front of the femur, rotate it away from the midline. So again, same basic setup as we saw in the shoulder. Then our other joint there is your tibiofemoral joint, which is the knee. So the knee joint complex actually has, the primary joint is the tibiofemoral joint, which describes the relationship between the tibial plateau there, which again, your tibia is your shin bone, and the condyles of the femur. So that's the primary hinge joint of the knee, is the tibiofemoral joint. But you also have the patellofemoral joint, which is the patella sliding on the condyles of the femur. And then technically you have the proximal tibiofibular joint. So that's kind of off to the side over here. That's your tibiofibular joint. So hopefully that one doesn't move. That one should be pretty immovable. So we don't really talk about that one much. Occasionally you'll have problems with tracking of the patella, where it usually pulls laterally, and so it starts to grind and catch and click and all that stuff on the femur. Usually as people drop into a deeper squat, they get what's called crepitus, which is kind of a crunching sensation whenever you flex the knee. So in terms of movements at the tibiofemoral joint, so again, primary hinge joint of the knee, you get flexion, which is bending your knee, extension, which is straightening your knee, and then we also have internal and external rotation. And you can only do those two when the knee is, or when the leg is non-weight bearing. So if you pick your leg up and you're not standing with your full weight on it, you should be able to take this really obvious knob there in the front of your knee, in front of your shin, and turn it toward the midline. That's internal rotation. And then if you take that really obvious knob there, the tibial tuberosity, and turn it away from the midline, that's external or lateral rotation. So those are the 4 movements you get in the tibiofemoral joint then. Flexion and extension, internal and external rotation. And other than the ligaments, which like I said we'll cover in class on Thursday, then that's all that you need to know for this week's lab. So we'll see you on Thursday.